So with our program, what we try to do, I'm trying to zoom in and it's not working. Sorry, it's not that easy to read unless I zoom in, but I'll tell you. So standard prenatal care in the United States is about 12 to 14 in-office visits. And the World Health Organization, ACOG, ACNM, we've all noticed that people need a little more flexibility in that. And probably that's too many visits. They also need flexibility in how we can access people and more convenience because of families' needs. And so before COVID, ACOG released a statement in February of 2020 saying, hey, we need to start using virtual visits more. And so we started talking about that around that time. And so the purpose of our program is to provide a more easily accessible approach. COVID hit and it happened that we just switched right away, but we wanted to continue with it to develop a more innovative approach. So our approach is that we use a registered nurse to perform the prenatal visits with our low-risk patients. She meets weekly with the attending of our clinic. It's a resident-run clinic at Virginia Hospital Center that provides care to low-income and self-pay patients or Medicaid patients. So she meets weekly with them, they decide who should be approached, and then she does the visits and then consults with the physicians and the residents after the visits to decide if anything else needs to be done, lab testing. She goes by established protocols and scripts that we have given to her, so she's not practicing outside of her scope of practice, but she's working in conjunction with the physicians as a medical team, similarly to how we would in an inpatient setting. So our evaluation of our program was done. We have qualitative analysis. Usually we just use a Lyme survey for these patients. We have a QR code that they can click, or we give them an email link for some qualitative data on their feelings. And then we've gotten outcome data for deliveries and patient outcomes that we would normally on any delivery through the EPIC system. So what we found is that patients have a high satisfaction with this because it does give them flexibility. They don't have to take off work in order to come to a visit, and they don't have to pay for babysitters. And so there has been a significant decrease in our no-show rate. Now we're comparing the no-show rate with 2019 because it's not really fair to compare it with 2020 since people didn't want to come to the clinic based on COVID issues. So in comparison to 2019, our no-show rate went from 11% to 5% because there's much more accessibility for them. We had some people who didn't continue up till term with the program because they had medical complications. That was 3 people or 7%. And those medical complications, one had a preterm delivery, one had cholestasis of pregnancy, and then one had a termination. We did find that all the other outcome data, type of delivery and such, APGAR scores, and weight for all the people in this study, really there were no significance. There are 2 outliers. There's one outlier for the weight and APGAR score, but that was the 30-week delivery. Our C-section rate was 22% for a total C-section rate. Those were for breech and repeat. Our primary C-section rate just for the breech was around 14%. So we found, in conclusion, we've really found that this is a great way to utilize the nurse. We feel that in the outpatient setting, nurses are really not utilized enough, and they could really be utilized so much more in conjunction with the medical team. And so having them come in this way and working together with the doctors really has helped increase access, because now the physicians can see more patients that are high risk, or if they're attending deliveries, we aren't missing appointments for that reason. I think as we worked with incorporating this program, and if you decide to incorporate a program like this, and you're in a larger hospital setting such as ours, understanding the logistics and working with all the other departments is sometimes the most difficult part when you're working with IT to get Epic up and running, or you're working with billing departments to get billing codes. Those are things that are much more trying. Our patients were provided with a fetal Doppler and an electronic blood pressure cuff, so they could actually do their monitoring of themselves at home. And so the billing department trying to come up with a code to bill, despite the fact that we got a grant to provide this equipment, was actually one of our larger challenges. The virtual visits can also help to reach rural areas who don't have as easy access coming to the hospital or to the doctor's office. And also we can do other services such as diabetic education or mental health counseling. One of our patients in the Lyme survey mentioned that she felt that during her depression, the nurse that she connected with, because she saw her more often than the other residents and attendings, was like her only friend, because she was from out of the country and didn't have other friends here. So she felt like she could connect with someone. Other comments were just the ease of use and of the ease of talking to this nurse was huge. So finding the correct person to fill that spot is a very important part if you're going to continue using this type of program. They need to be sensitive. They need to be able to talk easily with people, and then have the good clinical judgment in order to make decisions and consult with the physicians as they assess people's progress and their prenatal care. So I'll be happy to answer any questions. I know it was a more of a quick